Practicing physician is one huge thing. Another huge thing is being an administrator, running an academic cardiology division, trying to make sure that there's high levels of quality. And fortunately, I'm blessed with a very talented faculty that is capable of having, at the same good outcomes and good patient satisfaction scores, as well as being just good people. And then my role with the college really has a wide variety of aspects to it, both domestic and international, trying to improve healthcare everywhere, which is our mantra and our mission. Before getting into the presidential team and meeting with them regularly, I thought that there was some competition, or at least co-opetition, okay, to make a new word. But the more I visit with them and talk with them and understand the structure of the ESC, I realize that they're actually not competing with us for members. They're actually an organization of organizations, first of all. We actually partner on many initiatives, and we're talking about doing more in the future. Everything from guidelines to educational programs to grassroots fundamental changes to how risk factors are handled, and doing some real major campaigns together. We're hoping to have those rolling out in the near future. Flattening the world, indeed, is something that we've been able to do in the digital era. And we, in the United States, at the American College of Cardiology, we're broadcasting everything back to the United States and making sure that we're responding and putting into the sort of United States context the science that goes on here, and then it happens in reverse when you're at the American Heart Association or the American College of Cardiology meeting. But we do, each of those three organizations has an international mission. We all are supporters of the World Heart Federation, for example, and the four organizations together really do work to try to improve heart health globally. And so it really is good to have partners and loads of communication, not like it was many years ago. Well, there are huge differences. They have to do with culture, genetics, finances. And so, just give you a few examples. When you meet with the Chilean Cardiac Society, they're very concerned about the recognition of hypertension, the treatment adherence, and getting to goal of hypertension in their society. It seems to be a growing problem. You talk to the Lebanese cardiologists, they're concerned about smoking in 6 to 10-year-olds. In the United States, we really have a plethora of diabetes in our Hispanic population. We actually, as well as obesity, and we have obesity and renal failure, stroke, and heart attack mortality that's been excessive for decades in the African American population. The guidelines that we create and the treatment algorithms really need to be refined for every area. If we give the high-dose statins, for example, to lower the risk in African Americans, it actually works pretty well. Use those same doses in Asians, there's more myopathy. And yet, if you don't do something, Asians have more strokes. And so we really do need to try and make sure that everyone is able to assess their own territory's risk and do what's best to try and use that data. And this is why we like to do registries, and we like to internationalize those registries. And you do some cross comparisons, but those registries on a local level can really influence how treatment is done. Well, it has to be. We've had some very large inroads with our Pinnacle registry, which is our outpatient registry, and some pockets here and there. We're trying to work with Canadians, for example, who have a plethora of registries. They're all sort of different provincially. Get them to talk to each other using similar platforms to what we use is one goal. But we've had a couple of recent successes that have been published. The Pinnacle registry in India, Pinnacle registry in Brazil. Really being able to give the practitioners in the outpatient clinics feedback about how often they're following their guidelines and how often they're reaching success. And so this is something I think that really can help. And you take that to China, work on smoking, try to improve outcomes on a large scale. So I'm very happy that my presidency will end in Chicago, since I'm from Chicago. The McCormick Place is on the south side of Chicago, where I'm actually from. It'll be a very nice time. We've had plenty of meetings there in November and March in the past. They're always very successful meetings, part to do with the attraction of Chicago as a city, but partly to do with the fact that it's just easy to get to. And so being central in the United States, we hope that we'll have enough international flights to attract folks, which usually does happen. We actually haven't had a meeting that was bigger than our 2008 Chicago meeting yet, so we're hoping to at least equal or surpass that. You have a lot of medical centers. Rush University is not the only one, and when that happens and you have a local meeting, you get a lot of walk-ups, which can be very helpful to adding to the science and the buzz in the hallways. So we're looking forward to a special meeting, and I should mention that it's a little later than usual. So that means a couple things. One is 13 months of presidency for me, and the fact that we're in April instead of March does actually mean that it might be just a little bit warmer than other times. There really tends to be big news no matter what, and sometimes you go to a meeting and all of the major trials turn out to be negative and people are disappointed, but at least they're there. When you have positive trials that are going to change how things are viewed and how things are done, PCSK9, neprilysin inhibitors for heart failure, and the like, for recent examples, it really does create a buzz that's long-lasting, and folks are looking for even more education after the fact.